Hello everyone, my name is Shehun Ibrahim Balogun. Today is November 16, 2021, and I will be discussing my case presentation on Mycobacterium tuberculosis, often shortened as TB. For a typical patient presentation, a 40-year-old homeless male was admitted to the hospital after 1 week of cough, chest pain with coughing, night sweat, fever, loss of appetite, and hypersomnia. He was seen by an ER physician who noted signs of depression. The patient also has a history of intravenous drug abuse and hepatitis B. So, what is the underlying cause for tuberculosis? TB is an infection caused by Mycobacterium tuberculosis, an acid-fast bacillus that usually affects the lungs but may invade other body systems if not treated early. So this is the background information on TB. TB is the leading cause of death from a curable infectious disease in the world. TB cases have increased greatly during the mid-90s as a result of acquired immunodeficiency syndrome, which is also known as AIDS, but has decreased since 2000. 2 billion people worldwide are infected with TB, but about 90 to 95% aren't aware that they are infected because they are not showing symptoms. There are 2,000 deaths per year globally, with highest mortality rates among those who are HIV positive. 10% of diagnosed infections will progress to active pulmonary tuberculosis. I would explain that later, like the differences between latent and active TB. Emigration of infected individuals from high prevalence countries, transmission in crowded institutional settings, homelessness, substance abuse, and lack of access to screening and medical care have contributed to the spread of TB. So what are the risk factors for TB? Both males and females of all ages are affected equally. Because TB is an airborne disease, people that live in crowded conditions, people that are homeless, people that travel a lot, frequent travelers, people with immunodeficiency are at risk of having TB. So what is the pathophysiology of TB? TB is highly contagious and is transmitted from person to person in airborne droplets. In immunocompetent individuals, the microorganism is usually contained by the inflammatory and immune response system, which results in latent TB infection and is associated with no clinical evidence of disease. More pathophysiology. Once the bacilli are inspired, they lodge in the lung periphery, causing localized, non-specific lung inflammation. Some bacilli migrate through the lymphatics and become large in the lymph nodes, where they encounter lymphocytes and initiate the immune response. Once the bacilli are isolated in tubercles and immunity develops, TB may remain dormant for life. If the immune system is impaired, reactivation with progressive disease occurs and may spread through the blood and lymphatics to other organs. Infection with HIV is the single greatest risk factor for reactivation of tuberculosis infection. More pathophysiology. With this slide, you can see the differences between latent TB and active TB. So with latent TB, it's pretty much when an individual has been exposed to the bacillus and infected but does not have active disease and is asymptomatic. That means the patient is not showing any symptoms. Whereas for active TB, People with low resistance, primary infection may not be controlled, but instead progresses to active infection, spreading through the lungs to other organs. So pretty much with the active TB is when the immune system is compromised by AIDS or aging, the infection can spread to upper or lower lobes. More pathophysiology. So this is a diagram slide. So as we all know, TB is usually transmitted via inhalation, which is how they gain entry into the lungs. TB can avoid mucus traps and makes its way to the alveoli and deep airway. And this is where patients who have signs of infection after exposure to TB, and most are asymptomatic. That means they are not showing any symptoms. So after 3 weeks after initial infection, cell-mediated immunity kicks in, and immune cells surround the site of infection, creating granuloma, essentially an attempt to wall off bacteria. But when the immune system is compromised by AIDS or aging, infection spreads to upper and lower lobes of the lungs, which can cause bronchopneumonia, but it can also spread via vascular system, affecting every other tissue in the body. More pathophysiology. So with this slide, it's a large-scale X-ray of the different types of TB and what they look like. And as you can see, with a healthy non-TB, this is what it looks like, and sick non-TB. And pretty much with an active TB is where the infection is spread to the upper and lower lobes. And as you can see, like it's a fibrous scars, so they are clearly showing symptoms. And with a latent TB, it's just a person with an infection, but no symptoms. So what are the symptoms of TB? Well, you have to classify them into two distinctions, which are the latent TB and active TB. With the latent TB, is asymptomatic, which is the patients are not strong symptoms, but they are infected. And with an active TB, the symptoms could be a cough that produces purulent sputum, develops slowly and becomes more frequent over several weeks or months, loss of appetite, fever, fatigue, chills, night sweat, dyspnea, chest pain, and hemoptysis may occur as the disease progresses, and it is more common in HIV-infected individuals. So how do they diagnose TB? Well, this is testing for TB starts with PPD, intradermal skin test, which is sometimes known as tuberculin test or TB test. With this test, tuberculin is injected between layers of the damage. Tuberculin is a component of a bacteria. If the person has previously been exposed to TB, the immune system will react to the tuberculin and produces a small localized reaction within 48 to 72 hours. If the reaction creates a large area of induration rather than just redness, it is considered to be a positive test. A positive tuberculin test simply means patient has been exposed at some point of TB. This does not differentiate between active or latent TB. Also, another alternative to PPD would be IgRA, which looks for evidence in the blood or previous exposure to TB protein. So pretty much IgRA is a blood test. You do not need to show up again to have the test read like how you do with a PPD. Also, IgRA is more specific to TB rather than other types of microbacterial injections. It is unlikely to be positive as a result of having BCG vaccine in the past. The vaccine protects against TB. BCGs are given to any children around the world to prevent disseminate TB. After doing a screen test with PPD or IGRA, anyone with a positive result are typically referred and they get a chest x-ray to look for signs of active TB. In patients with symptoms like fevers, night sweat, coughing of blood, it is important to also collect samples from sputum. So these samples are sent to the lab for staining and culture and PCR to look for evidence of Mycobacterium tuberculosis. So how do you treat TB? With the treatment for latent TB is using single drug for a prolonged period of time. The most common approach is using isoniazid for 9 months. And the treatment for active TB is done with different combinations of anti-TB and antibiotic like isoniazid, rifapentine, ethambutal, and pyrazinamide, which results in patients being non-infectious within few weeks. And also, there are new vaccines currently in clinical trials, and treatment of TB, HIV co-infection requires monitoring of drug interactions and toxicity. And this last slide is my references for my PowerPoint presentation. Thank you for listening.